So thank you for joining. This is now the part of the day where we take our panel votes on clinical effectiveness and value, and that's long-term value for money. We're not going to vote on the total affordability or budget impact of these medications. There is, for the voting panel, there is a link that you should see in the chat box to make sure that you can vote. If everyone could just make sure that that is working, that would be helpful. Okay, if any, speak up now if anyone is having trouble, but I don't see anyone having trouble, which is great. So let's go to the first question. Becca, are you advancing the slides? Okay, so first we'll reference the patient population that is of interest. And this refers to this is pertinent to all of the questions that we'll be voting on. These are adults, not children, not adolescents, with obesity or adults with overweight in the presence of at least one weight-related comorbid condition who are actively seeking medical management for weight loss. These are people without diabetes. People with established diabetes are excluded, given the differences in indications for these medicines for individuals with diabetes. Next slide, please. So in terms of the clinical evidence votes, the first question, and maybe, so I'll just kind of start by saying that we do have a lot of questions today. So we want a robust conversation, but also sort of, I'll have to move people along. Is the currently available evidence adequate to demonstrate that the net health benefit of injectable semaglutide added onto lifestyle modification is greater than that of lifestyle modification alone? And maybe I should give Dr. Lin a moment to direct us to the right part of the information packet.
Yes, thank you, Jason. So if you look at your evidence summary, you'll note that table 1 shows all our ratings for injectable semaglutide versus lifestyle modifications. We gave that comparison A, which is a high certainty of substantial net health benefit. And that's based on data from table 2, which is the weight loss data for injectable semaglutide, showing substantial weight loss compared with lifestyle modifications, and table 6, which is the cardiovascular outcome trial, which shows a decrease in cardiovascular events, along with table 7, health-related quality of life improvements for injectable semaglutide.
Thank you. Questions or comments from the panel? And you're welcome, the panel's welcome to make any questions or even like declarative comment is welcome too, just to, as we kind of deliberate together on this. I think we don't have any. This is one of the more straightforward ones that we've had. Okay, I guess hearing none, I'm not sure actually we have everyone back, but we will proceed with I think there's maybe one person who's not back, but we will, oh no, I think everyone's back now. Thank you. We will proceed to vote. I am not, okay, here we go. 14-0, so pretty definitive result. And I guess given the unanimity, I won't ask people to sort of explain their thinking. Next question, please. The next question is the currently available evidence adequate to demonstrate that the net health benefit of oral semaglutide added onto lifestyle modification is greater than that of lifestyle modification alone? So this is oral semaglutide. Does anyone want to make any comments or ask questions for the research team?
And I'll just remind you again that we gave this comparison an A rating And the tables 3, 5, excuse me, 3, 6, 8, and 10 in the evidence summary will give you data on weight loss, cardiovascular outcomes, quality of life, and harms.
Thank you. Questions or comments from the CPAC?
Just a reminder, when voting, should only be members of the New England CPAC voting.
Yes, I think we had a 15th vote come in, which doesn't make sense for our 14-person panel. So we'll confirm that. I guess without comments or questions, we can go ahead to vote on this too. Fourteen to 0. So unanimity. Next slide, please. So the third question is the currently available evidence adequate to demonstrate that the net health benefit of tirzepatide added onto lifestyle modification is greater than that of lifestyle modification alone? Grace, do you want to say anything about this?
Sure. Again, we gave this comparison an A rating, and tables 4, table 6, table 9, and table 11 will give you the relative information on weight loss, quality of life, cardiovascular outcomes, and harms for tirzepatide.
Thank you. So, Grace, I'll been on this panel for 10 years. I'm not immediately sure I ever remember an A rating. It may have been one that I just am not remembering. I mean, this really is it sounds like you guys are very confident about this assessment.
Yes, Jason, thanks for that question. I think, the magnitude of benefit in terms of weight loss is very large. We do have some uncertainty about the cardiovascular benefit, but compared with placebo, compared to lifestyle modifications, it's clearly people get substantial net benefit based on the clinical trials. And we didn't even much consider the other conditions that's being studied for, whether it be MASH, whether it be, obstructive sleep apnea. There are other benefits just beyond weight loss and cardiovascular outcomes. And so we felt pretty confident that, at least compared to lifestyle modifications, these drugs were superior.
So even acknowledging the heterogeneity of evidence about cardiovascular outcomes, even if this may be a class effect, but even if it wasn't, there are other clinical endpoints that this seems to improve. Okay, feel free to vote. I think we already have 12 votes, 13 votes, 14 votes. Let's see the results. 14 to 0. All right. Grace, you've convinced us. Next slide, please. So this may be a little bit more nuanced now. Question 4 is the currently available evidence adequate to distinguish the net health benefit between tirzepatide and injectable semaglutide? And if yes, which has a greater health benefit? So it's a sort of tiered question here. The first, first thing is there evidence to distinguish the two? And if yes, which one has the greater benefit? Any comments from the research team?
Yeah, this is where it starts to get a bit more interesting, right? I mean, we have one head-to-head trial for this. This is SURMOUNT-5, and those results you can find in table 5, where tirzepatide does have greater weight loss than injectable semaglutide. But then when it comes to cardiovascular outcomes, we have data for semaglutide from the SELECT trial in a population of people with obesity, with cardiovascular disease. We don't have similar data yet for tirzepatide. Those data, the SURPASS CVOT trial, comes from the type 2 diabetes population with cardiovascular disease. So not the same population. The other issue is that the tirzepatide trial was compared with dulaglutide. Now, dulaglutide has been shown to have cardiovascular benefit compared with placebo, but we don't have that direct comparison of either tirzepatide versus placebo or tirzepatide versus semaglutide. In terms of health-related quality of life, and in terms of harms, those both drugs seem fairly similar in terms of their improvements.
Any questions from the voting panel, or also feel free to just make points that you want to make. Jim, I think your hand's up.
Thank you. There's a certain ambiguity about net health benefit to my ear. Maybe you could help clarify. Like the excess weight reduction of tirzepatide do we consider that itself a health benefit, or do we only consider a health benefit the sequela of that?
Yeah, I mean, I guess my answer would be it's up to us to deliberate about how we interpret that. I mean, we have heard a bit today about quality of life endpoints that are pertinent with these agents. I don't know, David, do you want to add something about that?
Sure. I was going to talk to a different point, but I will say that we certainly considered weight loss to be a patient-important outcome on its own, and that there's evidence on quality of life improving. People take these drugs with a goal of weight loss, independent to a degree of other downstream health benefits, which also occur. So yes, we do think that weight loss on its own provides a health benefit. Net health benefit would mean that outweighs any harms on the other side. And I think we probably would have said, even if, and we actually did say, we had conversations about this, even if all these drugs did was be completely neutral on everything else and cause the weight loss we were seeing, we would have thought that there was a substantial benefit because of how much people value that sort of loss of weight. The point I wanted to make was why we've stressed so much around the cardiovascular, and how small the uncertainties would have to be to leave us unsure what to do. Imagine that tirzepatide is as much better as it is on weight loss than semaglutide, but the reduction in cardiac events, instead of being a 20% reduction, is a 17% reduction. So you only decrease events by 17% rather than by 20%. And then you multiply that by treating 100 million people. And you can see why it's so important to know which of these drugs is better on cardiovascular benefits as we look at this. It's so important. It's what comes up with statins. It's what came up with the clot busting drugs. It really matters. Small differences on the #1 cause of death in the United States matter a lot.
Can I just ask a follow-up question before to the original question? Are we confident? How confident are we in asking this maybe to Grace that tirzepatide is more effective in just the weight loss dimension? Taking your point, David, about the cardiovascular importance of cardiovascular.
Yeah, thanks. I think that we have a head-to-head trial. I don't think it gets head-to-head randomized controlled trial. I don't think it gets any higher standard than that. And tirzepatide does have greater weight loss head-to-head versus injectable semaglutide. So I think we're quite confident that, and that is, about that outcome. I think the uncertainty is around other outcomes.
And the magnitude of the difference is significant. It's not just statistically significant. It's a substantial difference in weight. Yeah.
Yes. Yeah.
Thank you.
And just to be very explicit about this, Grace, because it sounds like this question's really going to turn on this. Your confidence sounds a lot less about cardiovascular outcomes differences between these two medications.
Mm-hmm.
And we just heard from David Rind that difference on a population basis would be tremendously important because cardiovascular events happen to so many people.
That's correct. And that's actually what drives the promising but inconclusive rating, that small chance that if tirzepatide is worse than injectable semaglutide, it might have net negative health benefit compared with injectable semaglutide, even if it shows greater weight loss.
So even if injected semaglutide doesn't have quite as much weight loss. If it potentially has a slight benefit or meaningful benefit for cardiovascular outcomes, there could be a bit of a wash here in terms of which is better in terms of overall health status. Is that a fair representation of your views as well?
Yes, exactly.
Austin, Dr. Frack, do you want to go ahead?
Thank you. Yeah, Jim alluded to this, but I wonder if we might hear for a moment from our clinical experts about the clinical significance of the difference in weight loss. And I want to put a finer point on this. So if I'm reading this right, it's 13.7 adjusted % weight loss on one versus 20.2 on the other. And the way I think about this is not as averages, but as the marginal difference. In other words, if you have a patient that lost 13.7%, what's the marginal benefit? Is it clinically meaningful to lose another, 6 point whatever %? And I just love to hear from that from clinicians.
In practice right now, it is very common that we start a patient on semaglutide because at least where I practice, that originally was easier to get someone on. And then when they plateau on that, we put them on tirzepatide and they continue to lose weight. That is a very common scenario clinically. In terms of, I don't know if you want me to weigh in about the cardiovascular benefits. I totally agree.
We'd love your thoughts on all of this.
Yeah, I totally agree that we need to wait to see what the clinical trials are for cardiovascular benefits with tirzepatide, because I think there are GIP receptors on the heart, but I don't know if they're going to have an independent effect. Whereas the GLP, the semaglutide, it seems that some of the effect is on cardiovascular outcomes are independent of weight loss. So, and I don't know if we'll see that or not with tirzepatide. So the weight loss is really important, and I expect that it'll be just as good in tirzepatide, but I don't think we know yet.
That's super helpful. It sounds like there's consensus that we shouldn't assume that more weight loss is going to be parallel to changes in cardiovascular outcomes, even with enough statistical power to distinguish in trials. Dr. Trio, did you have something to add to this?
I'm just going to say it's pretty similar. I don't think we can assume there's a linear relationship with the weight loss and the cardiovascular benefits.
Thank you.
And I just to Austin's question, I just want to go one step further, which is, I do think you can both look at it as the mean weight loss, the sort of 14% versus 20%. And I think for many people, that is very meaningful. You're talking about, imagine somebody who weighs 200 pounds going down by 26 pounds, versus 40 pounds. Those are important numbers of differences. But also when you look at the percentage of people who hit certain percentages of weight loss, we sort of, you can look at how many people got 20% weight loss, 25% weight loss. You see a percentage of people with tirzepatide, as an important percentage, losing a quarter of their body weight, which you don't see nearly as much with semaglutide.
Yeah.
And if I might add, I think there are certain medical or weight-related conditions that respond to more weight loss. And so, yes, when people lose 5 to 10% of their weight, lots of their lab values are improving and things like that. But when you want to get meaningful improvement in pain from your osteoarthritis or get off of your CPAP from your sleep apnea, you do need to lose more weight, and getting to those higher percentage of total body weight loss, I think, helps you achieve those outcomes.
The clinical outcomes that are more causally related to the actual body mass, I guess. Tara, Dr. Lavelle, do you have a question or point?
Yes, I just wanted to bring up a point that maybe the clinical experts could just follow up on briefly, but the question here about distinguishing net health benefit is looking at these two drugs on average. And from what I've read about this, that that sort of gives like an overall impression that these two drugs are interchangeable, right? Like a PBM could negotiate a higher rebate for one, and that's how they would pick whatever to put on the formulary. But from what I've read, like individual patients may have different side effect profiles for different drugs, right? So having both of them available, it may mean on average they have the same, or you can't distinguish the benefit, but for an individual patient, they may benefit from one and not the other. Is that true?
Uh,
Sure.
Yes, I could, yeah, so we definitely have patients who respond to one and not the other. Sorry, didn't mean to interrupt you.
No, I'm
So
sorry.
I do think having both available is definitely more beneficial to the patient. Currently, a lot of them since July, insurers are just covering one versus the other, and we're left to appeal when a patient doesn't respond to one of the GLP-1s. So it's much more patient-centered to have both available. We don't think we understand why some people respond to semaglutide versus tirzepatide.
This gets into a generalizable kind of ICER issue around heterogeneous
Yeah.
treatment effects versus average treatment effects, right? So that's always true. For if any medicine on average is better than another medicine, there still may be few individuals who will respond better. It's sort of a basic principle of heterogeneous treatment effects and average treatment effects. So I don't know, David, do you want to weigh in on this?
Only to say that I bet that Sarah is planning to discuss some of this on the roundtable. So I'm not sure we need to get too far into it, but I agree. You know, on average, people do better with tirzepatide, but you know, I have a patient who's just in the diabetes space who did way better on old diabetes drugs that aren't supposed to work than on a GLP-1. And I still haven't figured out what happened there. So, you know, I mean, like went totally out of control on their diabetes on a really good diabetes drug when they were well controlled on old bad diabetes drugs. So, you know, people get to have whatever their biology actually is.
It sounds like a heterogeneous treatment effect. Additional points that people want to make or questions before we vote. This is obviously a little more nuanced than the other ones we had so far. Okay, hearing none.
Just one, the difficulty I'm having in the vote is that the net health benefit has at least two dimensions. One of which it's clear and one of which it's not clear.
Right.
And so that makes it it's a logically hard problem to answer this question. Any guidance?
Yeah, no, I mean, I think, yeah, I'm not sure if others in the group want to speak up, but yeah, we have to integrate our relative importance of different health outcomes, as well as the level of certainty that we think that these things may or may not be different. But I think the question is overall to sort of improve overall health for a specific population. So they have to be interdigitated in some way. Does anyone want to say, you also can feel free to say what you're going to do, just if you can potentially persuade some of your colleagues if you want. Okay, if no one wants to speak up, why don't we proceed to the vote? Please speak up if anyone's having any trouble with the voting software. We expect 14 votes. Okay, so we have 13 not adequate to distinguish, and then 1 vote for tirzepatide. So normally, when it's only one person, we don't force them to speak up and say their rationale, but we would also welcome that person to speak up. Obviously, dissent is always helpful and can be incorporated into the final report. So we would love any, if that person wants to speak up, they're welcome to. Otherwise, we can move on. Okay, we will move on. Next slide.
Jason, I'll just note that we're getting 15, so maybe that one person isn't even on the panel. I don't understand why the number's 15 votes.
So I'll just say a reminder that it should just be the people on the panel. Anybody who's here as a clinical expert or a patient expert or anyone from ICER on here shouldn't be voting.
Should we retake that vote? Becca, can we do that with the software? I'm not sure.
Jason, I don't think we need to because we can control for it in the back end when we do the reporting out. And so I think we're good there.
Okay, thank you. We'll move on to question 5. Is the currently available evidence adequate to distinguish the net health benefit between oral semaglutide and injectable semaglutide? And if yes, which has a greater net health benefit? Maybe hear briefly from Grace on this.
Yes, so for this, we gave a rating of C minus, which is not a rating we give very often. And what that equates to is that we believe that oral semaglutide is comparable or inferior to injectable semaglutide. And we base this on the fact that oral semaglutide appears to have slightly less weight loss. And the fact that we don't have data on direct cardiovascular benefit at the weight loss dose. So the data we have is from a trial in type 2 diabetes where the dose is half, a little, well, I'm sorry, it's not half, it's 14 milligrams rather than 25 milligrams. So that's a little bit of difference in, we don't know what the difference in effect might be for that dose, for the 25 milligram dose. And then in terms of health-related quality of life, the oral semaglutide trials did not report out SF-36, so we don't have any comparison there. And then the harms seem similar. So we felt like because of the lower amount of weight loss, mean amount of weight loss, and because we didn't have good data on cardiovascular benefit in the dose that's proposed for weight loss, we gave this a comparable or inferior C minus.
Okay, and just given the unusual rating, I'll just read out loud. This means that it's a moderate certainty that the net health benefit is either comparable or inferior, with high certainty of at best a comparable net health benefit. Austin?
I'm pretty sure I have this in mind, but maybe it would be helpful to just really call out what changes between the votes we just took, which were P/I ratings, and the set of evidence, the differences in the qualitatively, the differences in the set of evidence that takes you from P/I to a C minus. I think I know what they are, but maybe just making that as crystal clear would be helpful for others.
Sure. So if you look at table the weight loss tables, the mean effect for injectable semaglutide is somewhere in the 13 to 15% range, 14 to 15% range. For oral semaglutide, it's a little bit lower, and about 14.6%. And that's just from the one trial, OASIS 4. In terms of the cardiovascular benefit, and that is from table 6, you'll see that select trial, the hazard ratio was 0.8 for injectable semaglutide. We did a meta-analysis of the SOUL trial and the Pioneer 6 trial. These were two trials of oral semaglutide in type 2 diabetes for cardiovascular event reduction. And that meta-analysis showed a hazard ratio reduction of 0.86. And that is at a lower dose than the weight loss dose. And in a type 2 diabetes population. So, you'd be extrapolating. But that is, we don't think, based on the amount of weight loss, that likely, and the hazard ratios from the diabetes populations, that likely oral semaglutide has a greater effect on cardiovascular outcomes than injectable semaglutide. Hopefully that's helpful.
Which is to say that you think that there's more evidence that injectable is more efficacious in cardiovascular outcomes.
Yes, or comparable.
Or comparable.
Comparable. We don't think that it's injectable semaglutide is worse than oral semaglutide.
Dr. Schwartz, Jason?
Yeah, my question picks up actually, Grace, exactly where you, Dr. Lin, right where you left off. Since the C minus is the oral semaglutide compared to injectable, that would mean, if I'm following the evidence matrix correctly, that if it was framed in the reverse way, injectable semaglutide to oral semaglutide, that would mean, am I correct, that you would give that a C plus because there's that possibility of the benefit, but not the negative? Am I understanding those relationships correctly?
Yes, that's correct. We don't think that injectable semaglutide is inferior to oral semaglutide, but oral semaglutide may be inferior to injectable semaglutide.
Thank you.
Appreciate it, Grace. That was a fantastic explanation. Thank you. Maybe go to Joe Porter. A question.
Thank you. Just want to be sure we're clear then when ICER takes this on, because Dr. Lin, you've talked a couple of times about the weight loss dose, we are not contemplating efficacy if doses were changed, correct? We really are focusing on the evidence as it exists in the trials.
Let me just make sure I understand that question. So the evidence presented from the cardiovascular, for the cardiovascular data, yes, is from a different dose, 14 milligram dose, and we're not, we're not extrapolating that to the 25 milligram dose. We're just
Okay.
stating that that's the evidence we have.
Okay, perfect. Thank you. I wanted to make sure I was understanding the dosing on the C minus. Thanks.
I recognize the nuance here, so I want to bring out the conversation, but I also want to make sure we're moving ahead. Maybe I'll just take one more from Jim Rebitzer.
Thank you. Just as a question for the providers, the big difference between these two seems to me to be the form, a pill versus an injection. And I'm curious in terms of, since we talk about net health benefit, are there big advantages to having a pill in terms of getting people to take the drug or reaching populations that you couldn't reach if you just had an injectable?
You're going to get to vote on that in just a minute, so let's stay away from that for this vote.
Excuse me, sorry.
No, it's an important point, but it's in a different part of this. This is just health status, and then you'll have a chance to talk about mode of delivery as a contextual factor. All right, I guess with that, let's vote. I'm gonna try to see where the numbers are. I don't see them yet. Feel free to speak up to me or Chloe or anyone if there's a technical difficulty. Okay, we have the right number of votes, which is good. So 9 not adequate to distinguish, and 5 people thought that injectable semaglutide had a greater net health benefit. So I think given the conversation earlier, I think there was some sense in the room of the differences of opinion and the rationales for it. Maybe does anyone for the injectable semaglutide want to be very explicit about why they voted the way they did? Or the not adequate to distinguish? Okay, I guess not. We will move on. Next slide, please. So this is another set of questions that attempts to kind of go beyond qualities to sort of, are there contextual factors that we should consider in our assessment of the value of these medicines and the relative value of these medicines that are beyond health status and may touch on to sort of societal factors or ethical priorities. Next slide, please. So the wording of these questions are to help inform judgments of overall long-term value for money. Please indicate your level of agreement with the following statement. So essentially, our basic assessment of long-term value is related to our assessment of how well these things work or which one works better relative to the cost. But there may be contextual factors that are important in our assessment of the long-term value of these options, which we are about to deliberate on. Next slide, please. So the first one is so referent to overweight and obesity as a condition. There is substantial unmet need despite currently available treatments. And so I think what I heard from the research team is that this is a very prevalent problem in the United States. Would love to hear anything more. Grace, you want to say about this?
Sure. So I think this is unusual in that this is a condition where treatments exist and effective treatments exist, but they are not getting the access is poor. And so and some of that is affordability, but some of that may be just if we had more options, we may be able to treat more people.
Right. I guess this is a little bit unusual because these things are in clinical practice already. Often this question is asked when something is new.
I'm wondering if we can push it a little further to the clinical experts, though, to talk about people who maybe, even with tirzepatide and semaglutide, presumably not everybody you're treating feels like they're getting adequate responses. And again, if this condition is in 40% of people, that could be a lot of people. So what percentage of people do you feel like you're succeeding with when you use these drugs?
That's a hard question. I think I get a significant number to lose weight and feel happier, but it certainly isn't everybody. And also, people don't lose weight forever. It's not like you keep going on it, you can't lose weight. No matter what treatment we have right now, eventually you get a plateau. And so the question is, are you getting a plateau at the weight and the health that you want to be at? Or do they need to go further? Is there another treatment? A lot of times they'll then get bariatric surgery, or they'll get bariatric surgery, do well for a while, and then go on the medications. And there's a lot of new medications that are coming out. We just had Obesity Week. There are a ton of new medications in the pipeline. So I think that this unmet need will continue to get more met. But I don't think the scope of the problem, I do think the more options, the better. And even with the oral, not everyone wants a needle, an injection, and not everybody. And then the pill that we have, that the semaglutide pill, it's not FDA approved yet for obesity, but even for diabetes, it's not that easy to take currently, and there's new ones coming out. So I don't think we've reached the saturation in options.
Dr. Trio, did you want to add anything, or you don't have to?
Yeah, I agree, and I do think there are non-responders in the drug trials, and I think clinically we see that there's even more non-responders. So there are patients who I think don't benefit from the drugs, and of course it is much more tolerable than some of the other oral anti-obesity medications side effect wise, but we still have patients who can't tolerate them due to refractory heartburn and things like that. So I do think there is still some unmet need.
I wonder if we could just actually hear briefly from the patients too about this, given the question is around unmet need. Does anyone want to say anything? You don't have to, just wanted to give you an opportunity.
No, I agree with what's been shared so far. I think the reality is, okay, we have a couple good medicines, but is that enough to take care of everyone? And we sort of rested our laurels around bariatric surgery all those years ago, right, kind of thing. And then not that many people utilize bariatric surgery because even though many people probably should, but because it's not considered a therapy that many people want to do. So I think the reality is we need more medicines for all, and plus all the reasons that our clinical friends shared as well.
Yeah, I would agree. I think the top three things that come to mind in my own experience and watching other folks like me would be access, awareness, and effectiveness. So I think that there's still many providers who are not even offering these treatments to people. I think that oftentimes when people are offered the treatments, they don't have the money to be able to even to pay the copays, and even with the reduced cost programs, it's still not attainable. And then I also agree with Joe that there's still many people who are on these medications and maybe they're not getting an effective response, or maybe they're getting the metabolic response without the large weight loss. And so that becomes discouraging as well.
These will be important issues in the policy roundtable, I'm sure. So I'm just conscious on time. I have maybe Dr. J, did you want to say one more thing? And then I think there's a couple more questions and then we'll move on. I think
sorry about that. I want to amplify what Michelle just said. We talk about unmet need. I was thinking just about medications, but I think there's a huge unmet need for social determinants of health, for lifestyle, for all the other things that people need when they're on the medicines.
No, I think that's helpful. That is within scope, I would think, this question. Austin?
Yeah, I'm trying to weigh the relative importance of unmet need due to cost factors versus unmet need due to clinical responsiveness or whatever the right term might be. And I'm a little concerned if I am convinced that it's really predominantly a cost thing, and I vote, for example, that I agree. how that factors into ICER's thinking or reporting about where the appropriate price might be. So does that question make sense?
Right, it does. I think part of it is the sort of unusual situation where something's in widespread clinical practice, and I think this is part of that. I guess my vote on the vote would be to not include assessment of cost as a barrier, although I would welcome input or disagreement from David, for example.
I agree with Jason on that, I would be thinking about this in terms of the condition and treatments for the condition, not so much whether cost is preventing people from getting, I mean, obviously that's a huge deal for ICER, whether cost is preventing people from getting access, but I don't think that's really what we're trying to get at with this vote.
We definitely get it with another vote. Stephanie, Dr. Vale.
Thank you. Not a question, but just a comment as I think about and wrestle with and answer this question, which is access is also limited in this disease state by stigma, and that was mentioned earlier. And I think both by providers, as one of our patient experts just mentioned, both by providers not offering and by patients not requesting obesity care and treatment, maybe because of self-stigma. And this contributes to unmet needs, and these drugs also can help reduce the stigma by reducing the need for sort of like willpower that is a common sort of thought around obesity and overweight. Further, can help it on psychiatric pharmacists. Further, people with obesity have co-occurring psychiatric conditions often, or substance use disorders, or maybe both, and are already impacted by reduced access to adequate wraparound care in general, and are often less likely to be offered evidence-based medical care for obesity and other conditions. So I think about all those things as I wrestle with this question.
Yeah, I mean, that seems to be for sure part of the scope. And we, the CEPAC is great for many reasons, but one is that we all integrate diverse expertise, and I appreciate your bringing your expertise to the table in that assessment. Other questions or concerns, or does anyone want to say anything before we move to a vote? I don't see any, so let's go to vote. Oh, or Steve, do you want to, we've started voting. Do you want to say something or ask a question? Yeah, feel free to.
Yeah, I just wanted to plant a seed about this part, despite currently available treatments, and there are other treatments that are available, and some payers are requiring patients to step through them to get these medications. And so, as I say, planting a seed, something for the policy roundtable to think about with regard to payer policy and requiring patients to fail medications that probably, in many cases are going to be problematic to put them through those paces in the first place.
No, appreciate the importance of the point. And I do think that I know we have manufacturers on the policy roundtable, and there's a representative from IPD Analytics. So I'm sure this is going to be a robust conversation about step therapy and these other topics, which are really important. I appreciate the point for sure. In terms of the vote, I do not see the voting numbers right now, and I think it's because if anyone hasn't voted, please vote. Okay, so 257. All right, so good. We have 14. So most people voted strongly agree. Some voted agree, and then a couple voted neutral. No one said strongly disagree or disagree. So I'll leave that as it is. Next slide, please. The next question is, this condition is of substantial relevance for people from a racial or ethnic group that have not been equitably served by the healthcare system. Grace, do you want to remind us your findings on this topic?
Yes, thank you. Obesity is obviously a very prevalent disease. It has greater prevalence in the non-Hispanic Black population and in the Hispanic population over the white population. And we calculated the Health Improvement Distribution Index for those subgroups, and we came up with, for the non-Hispanic Black adults, a ratio of 1.2. And that means that, if we were the treatment as applied to that group would have potentially a 20% greater impact in that group than it would be in the reference white group. And for Hispanic adults, the ratio was 1.1.
So these ratios basically reflect the prevalence of the disorder in specific race and ethnicity groups relative to the overall population. Does anyone want to say, Stephanie?
Thanks. I'm the most polished one, so I didn't have time to write it up. But I just I think about the link between trauma and obesity, and I think about historical institutional and other sort of traumas, and specifically racism, that have impacted certain populations of people, particularly people who are Black, particularly people who are Hispanic, and sometimes both. And so I think about those things in particular as I think about this question and how I answer it, I guess I'll say.
No, thank you for sharing that, for sure. Joe Porter.
Yeah, thanks. I think the only other thing that I wanted to add in this is to remember that for all of these treatment options, we're talking in addition to lifestyle modifications, and I want to be conscious of the fact that there are racial and ethnic groups who have a larger challenge getting to those lifestyle modifications easily that we talk about, and I just want to make sure that we don't lose sight of the fact that when we're saying we need to eat healthy and have access to physical activity, that's not always easy for all racial and ethnic groups. And so I want to be conscious of the additive effect of these medications to the other part of this that has historical inequities in being able to access the lifestyle modifications.
Thank you. Dr. J.
Yeah, and just to expand upon that, that directly impacts people's ability to tolerate the medications. I haven't seen research on this, but when my patients are eating at Wendy's, or if they live in a food desert, it's really hard to tolerate the medicines because fatty foods stay in the stomach longer, cause more nausea, cause more reflux. And so when you don't have access to healthy foods, it makes it harder to be on the medicine, even if the medicine were to be free.
What kind of diets do you typically recommend to minimize the GI side effects when you start people on these medicines?
Yeah, well, when they first start, pretty bland diet, small portions, but then making sure as they progress to have enough fiber, and then of course, when enough protein, not too much protein, but enough protein because we worry about muscle mass loss. We want people to do resistance training,
right,
as well. But yeah, I mean, we basically want a healthy diet, has enough fiber, enough protein, and depending on what side effects they're having most, then we might alter that diet. But constipation is one of the biggest side effects, and so preventing constipation from the
And
outset.
hydration is important too. It's a big piece of it.
Yeah. No, that's helpful, and presumably different populations have different access to these types of food, and even going to the gym to reduce muscle loss and so forth. Jim.
I'm sorry I'm asking so many questions, but I'm new to this, so I'm still trying
You're
to
welcome to ask all the. I cut people off when I have to, so go ahead.
Okay, yeah, good. When you say this condition, right, we're not talking about the treatments, we're talking about the condition, right? And
Yes,
that
absolutely.
condition we're referring to is obesity.
Yes, I actually, now that you asked the question, I'm not certain that it's obesity versus obesity and overweight, but yes, it's the condition.
Okay, well, right, yeah, fine. But yes. So the other stuff is real useful. I mean, what Dr. J was saying about diets and how the difficulty of finding adapting diets, but that's not about the condition of obesity itself is what we're asking about here, right? Or obesity, overweight, whatever the right categories are. Am I understanding that right?
Yeah, I mean, I think one could potentially, my view is that one could potentially integrate some of the challenges with having this condition with the condition itself in actual sort of population, sort of assessment of the condition population. I mean, this question is specifically about race and ethnicity groups, though, too. So, and the HIDE that we heard was an important way that we assess that. Let's go ahead to vote. Okay, so 9, yeah, we got the right number now. Strongly agree is 9, and then it's 4 agree, and 1 neutral. And I think given that we've had a robust conversation about this before, I will not ask people to justify their votes because I think a lot of the thinking has been made explicit by the conversation. Next question, please. So for these questions, these are the value votes. To inform judgments, to help inform judgments of overall long-term value for money, please indicate your level of agreement with the following statements. So again, this is factors kind of outside of the quality. This question 8 is injectable semaglutide compared with lifestyle modification alone is likely to produce substantial improvement in caregivers' quality of life. So this is relevant to caregivers or ability to pursue their own education, work, and family life. So the quality adjusted life here describes health status among the patients. This is questions about caregivers. So sometimes when we have conditions, for example, that cause paralysis, if you're a caregiver for one of those individuals, that may substantially limit your ability to work. And a drug that reduces paralysis may allow you to work. So that's the kind of thing that this question tries to capture. Maybe Grace, do you have anything to say about this?
Yeah, thank you, Jason. This was there isn't a lot of research on caregiver burden in this condition in people living with obesity, but we felt like, especially in the long term, you got long-term effects of potentially preventing severe knee osteoarthritis and knee replacements, decreasing obstructive sleep apnea, liver cirrhosis, diabetes. So in the long term, treatment with these drugs may reduce caregiver burden.
Dr. Ross.
Thanks, Jason. Grace, did you guys come across in your review of the literature any smaller observational studies on this topic? Not even about like sort of nighttime wakings in use. I'm sure it's not been measured in randomized trials. I was just curious if there was weaker evidence that suggested some of these benefits.
That's a good question. We did not, although we were mostly, when we were looking at real world evidence studies and observational studies, we were mainly looking at larger studies. And so there wasn't any in larger populations. So I'm unaware, but perhaps our clinical experts have some, know of some smaller studies that might show that.
No, I mean, I think there's a paucity of qualitative work in this area to really understand people's experiences. So
maybe that's an important research priority also for the policy recs. Stephanie, Dr. Vale.
Thank you. Point of clarification for this question as I think about it. What is the time frame? How long are we?
Right. Yeah, I think as I was listening to Dr. Lynn's explanation, I was thinking about, yeah, we have never scoped this as a specific time frame. I mean, again, I sort of showed my cards a little bit with that example about paralysis, right? So obviously in the moment, there's substantial burdens, but then if you think about it more, as Dr. Lynn was saying, over the lifetime, if someone has obesity and myocardial infarction and then heart failure, and then they can't walk across the house, that may actually be much more pertinent in terms of caregivers. To my recollection, we've never said that this only applies on a certain time frame. David, do you agree with that? Would you want to say anything more about that?
Yeah, I mean, we're usually, this is sort of for the panel. Right. I think it's a fair question. I mean, it'd be interesting to hear, obviously, from patients and clinical experts how they think about this. But if you want to think about caregiver burden caused by people who develop DJD or heart disease, or, it's all fair game.
Tara, Dr. Lavelle.
Yeah, just to add that, when we try to include caregiver burden as a quantitative estimate in cost effectiveness analyses, we try to include it in the same time frame as the analysis. So I would be thinking about this over the full duration, of the lifetime horizon used in the analysis. It's how I would think about this.
Okay, that's extremely helpful. So just to be explicit about this, the modeling approach in this sense at least doesn't take into the part of the consideration, but Dr. Lavelle is kind of proposing that we think about it during the same time period, because if it were to be included, that's how it would be done. And so I don't know if Ujang is on, but this is a lifetime perspective, right? In terms of the modeling approach.
Yes, the model was done in a lifetime horizon. Yes.
Great. Sorry, lifetime horizon, not perspective. Excuse me. All right. Any other questions, or should we proceed to the vote? We have 11 votes. We have 3 people, 12, 13, 14. All right, let's see the results. Okay, so the most common was 7 agree, 3 neutral, 3 disagree, and 1 strongly disagree. So pretty big range. I guess, I mean, I don't know if anyone wants to say anything more about this, but it sounded to me that people are implicit in the conversation is that unlike things like paralysis or things that, require a lot of immediate term caregiving needs, obesity may be relatively lower than other serious disorders, but then there could be consequences of obesity in the long run that affect caregivers more. That was at least my sense of the way that the conversation was going. Feel free to disagree with me if people had a different sense. Joe, do you want to add something?
I'll just say that of all the votes that we've taken, this is the least comfortable I've been with. I've been with the vote. I said agree, but I really felt like I was sort of speculating as opposed to basing it on hard evidence, just more on my clinical experience. So I just wanted to throw that out there.
No, I appreciate, and I think, that kind of dovetails with the comments earlier about research needs, and maybe that's something that could be potentially considered for the policy recommendations at the end of the process, is that there's clearly a paucity of qualitative evidence about the lived experiences of individuals living with obesity and those who care for them. Next slide, please. So this is the same 5-point Likert scale. Oral semaglutide compared with lifestyle modification alone is likely to produce substantial improvement in caregivers' quality of life and/or ability to pursue their own education, work, or family life. So similar wording for oral semaglutide. Austin, do you want to go ahead?
Yeah, I'll make this brief. I admit I'm making my votes kind of with a memory of other meetings where we heard for other conditions where we heard typically a lot of discussion from patients about and their family members about the burdens. And I have to just be honest, I haven't heard that in this meeting. So that is influencing how I'm placing my votes.
Yeah, I mean, I think I have the same feeling, honestly, Austin. I mean, I think we should probably hear from the patients on this, but I do think, yeah, I mean, we've deliberated on things like pediatric disorders where a parent is their entire life is around caregiving, and I think it's a fair point to make. It's not in any way to have a lack of compassion for the tremendous burden of this disease, but the pattern of the burden imposes on individuals living with it and their caregivers is maybe a little bit different than what we've seen for other disorders. But I guess to this point, we'd love to hear from the patients. Joe, do you want to go ahead?
Yeah, so I was debating saying this earlier, and I should have obviously, but I think the the range of obesity, overweight and obesity is very great, right? And I think that's affects this here, right? So for example, if you have very severe obesity, and for example, I have a loved one who has very severe obesity who cannot have their knee replaced because of their body size and therefore is confined to a wheelchair, then the caregiver might, that their spouse has this huge burden, right, kind of thing around that. But that's not everyone who lives with obesity has that, and that's always been our challenge in the patient community around obesity, is that some of us are affected in different ways along this, and that's what makes these questions so hard. So I realize everyone's struggling, and I appreciate that, and I appreciate all the comments that are made. But just recognize, I think, for some people with very severe obesity, even basic activities of daily living are not possible, right? But that's a relatively small percentage of the population that live with obesity. But just because we talked about scale and, for example, BMIs above 40 and things like that, about 10% of women live with a BMI above 40, but there are plenty of people who live with BMIs of 60, 70, 80, 90, where you might see more of these challenges with activities of daily living.
Yeah, no, and we appreciate your perspective so much for so many reasons, and appreciate the importance of that point, especially for the maybe relatively small but important number of people who have arthritis and can't have surgery and need a wheelchair. That'd be a very different kind of caregiver experience. I just want to make sure no one else has anything.
I think I agree with Joe that I think there's a spectrum, but I'll also add this, I think about my own personal journey, that I think that for family members and potential caregivers, there's an anticipated potential burden when people are living with obesity and maybe having difficulty overcoming the obesity. So I think that there's the very real actual burden that happens, but I also think that there's an anticipated burden, particularly as people begin to age and maybe kids are concerned about, well, how's mom or dad going to be able to be independent as they age, and what does that mean for their overall life, and how they may have to step up at some point if this is not under control.
Yeah, no, thank you again for that very thoughtful point. And I think that blends so nicely into what we had discussed earlier around the kind of lifetime perspective, your sense of the anticipated difficulties ahead downstream from this condition. I mean, this is a classic condition where there's some delay in the in some of the consequences of the condition. Next, all right, I think let's go ahead to vote. Unless anyone else wants to say anything. We have 9 votes, 12 votes. Almost there. 14 votes. Let's see the results. Okay, so neutral 6, and then sort of there's a kind of a normal distribution around this. Some disagree, some agree, and then 1 strongly disagree. So some range of opinion. And I think given the conversation, I'm not surprised there is a range of opinion among the voting panel. Next slide, please. So, similar question for tirzepatide compared with lifestyle alone is likely to produce substantial improvement in caregivers' quality of life or ability to pursue their own education, work, and family life. We've had such a rich conversation about this already. Is there anything different about this medication compared to the others, maybe from the research team's perspective or from the clinical experts' perspective? It sounds like not a lot of knowledge about how different medicines might affect this. Yeah. Okay, let's proceed to the vote unless anyone wants to say something. Okay, Kim, yeah.
I am the non-voting member, but just for the voters out there, I'm going to throw out kind of my opinion. I am struck by the votes that are coming in on these questions, because when I think about the evidence review and what we have out there, we don't have any evidence that this actually changes caregiver burden. And I would underscore what Austin had mentioned, that I think this is a great area for ICER to put in their report, that we need more evidence here. I think hypothetically, we could assume that it would reduce caregiver burden, but we actually have no evidence. So I am struck by what we're seeing in the voting.
Yeah, no, Kim, appreciate your comments. Yeah, you're not a voting member, but your input is always valued and welcomed, and we appreciate making the point. I mean, I'll just kind of unmask myself a little bit. I'm voting disagree because of some of these issues. I can conjecture that less obesity at one form of life may lead to less caregiver burden in the future, but there's not a lot of empirical evidence for that. And that's how I kind of land on disagree. I sort of think that there's a spectrum of opinion, but I think your point is very thoughtful and I appreciate you making it. Tara?
Yeah, I just kind of like follow up on that, Kimberly, just to say that I think if there was good empirical evidence that this is something that the team could have incorporated into the model. So a lot of times with these questions, I think about it in terms of we don't have a lot of data on this. And so just what would I expect given what I know with the disease? So I think that's one of the to put it out there, that's one of the reasons I struggle with these questions too. But I realize that the reason we have these sort of descriptive or qualitative questions at the end is because oftentimes there is a lack of evidence that can be put directly into the model.
Yeah. We are a little bit behind. Any burning questions that can be made very quickly? Joe, Porter.
I just want to say that to your point, Jason, for me, neutral in this just means I don't know. And so I don't know how other folks are voting, but to Kimberly's point, like we don't have we need more information in this. So it just personally, for me, that's neutral.
Yeah, and I think that's a very fair interpretation. I mean, you and I are making slightly different votes and interpreting it that way, but I think that's a very fair interpretation. I mean, I think the word likely is important, and so different ones of us will consider that differently. Let's go to head to vote. $14 votes. Thank you for voting so quickly. Neutral, looks like the Gaussian distribution is shifting a little bit. 5 and 5 neutral and agree, with 3 and 1 disagree and strongly disagree. So a little bit of a spread still. Next question, please. Okay, so this question is about, this has come up before, but this is important to be made very explicit, is that medicines can be better or worse on its effect on health outcomes. They can have different values based on those clinical effects and also the prices of the medicines. But this is meant to capture something different, which is that different medicines have different modes of delivery. And this is pertinent in this case because it may have different, it may have implications, especially on things around access. So this question is oral semaglutide offers a substantial opportunity to improve access to effective treatment by means of its mechanism of action or method of delivery. So there's obviously an injectable form of semaglutide as well that has a different evidence base. Dr. Vale, Stephanie.
Thanks. One of the things I think about this question is, obviously there's a lot of evidence around just like longer acting injectables versus oral, especially in the psych world, and helping with adherence. So that's like one thing. But the other side is that there is a population of people that do have a phobia sometimes with needles or just concerns about needles. I think when we're thinking about these medications for diabetes, people may have been more likely to have experience with injectables, insulin, or some other injectable medication. And that's not often the case in people who don't have diabetes. People who have obesity or overweight often may not have used an injectable for any sort of needle-based product on a regular basis. And so I think for that population of people, having an oral option can be a benefit. But what I'm struggling with here with this question is, how do I weigh like this population, versus like the whole population as I answer this question?
Yeah, no, I appreciate the importance of the point, and I appreciate you sharing it. Steve?
Let me defer to Dr. Triot, who might have a retort for that.
Thank you. Thank you. Well, and we'll get back to you, Steve.
Oh, thank you. Yeah, just a comment and also just related to the question in general, just a few thoughts to put out there for the voters. I think a lot of people have trouble remembering to take a pill daily, so kind of gets to your Dr. Vale's point that I actually find a lot of my patients, it's easier to just take it once a week. They have the one day a week they need to give themselves the injection. And the other complication, this is On the contrary, the thing that's hard about the injection is that it needs to be stored in the refrigerator and things like that. So I do think there's some heterogeneity of who will adhere better to the drug, depending on whether it's oral or an injectable.
Yeah, so this was something I had kind of, in cardiologists in the lipid space, we now have options that can be injected twice a year. And so that for some might be actually better, but then, if they're forgetting to take the pills, but if there's someone else who's afraid of needles, that may, do the patients have any thoughts about this? About, should we consider injectable better or easier for access than pills, or is it different for different people? Would love your perspectives on this.
I think it's different for
Well,
different people. Yeah, I
Yeah.
think it really, the convenience for some people, reigns supreme. So if they just have to remember it same day, same time, once a week. But then there's other folks that they're used to maybe taking a regimen of pills, and that can just be one more, and that goes along with it. But I think it really is quite variable based on the person and preference.
Is it tricky to take semaglutide at home injectable? I mean, how many people find it not too hard versus difficult or concerning?
I mean, I might be biased because I'm a nurse, so I find it to be I'm on I'm on one of the
You are used to
injectables,
it.
so it's really super easy. But I think that in the communities in which I hang out with people who take GLP-1s, most people find it to be very convenient and pretty simplistic and pretty painless. So,
The injected semaglutide.
mhm,
Yeah, that's helpful.
yeah.
Dr. J.
Yeah, the only other issue with the refrigeration is that it's harder to hide it from your family members if you don't want to be broadcasting that you're on the medicine. Hopefully, stigma around taking the medicine will change, but there's a stigma about taking the medicine for some people, and if they have to show their family or that can be an issue. Whereas pills, you can just like hide with your other pills.
Yeah, it's such a powerful point that you're making that leads into this stigma discussion that's come up before and isn't really an important part with this, an important component of the thinking about this specific condition.
Yeah, Melanie, that's a very provocative conversation.
I'm sure.
The only point I was going to make, Dr.
Yes,
Roxby, is that there are FDA-approved oral medications for obesity. They're not as effective and problematic, but just wanted to get that point out there that oral semaglutide is not the only option.
Thank you. Dr. Schwartz, Jason.
Yes, thanks. I just wanted to note I'm appreciative of all this discussion of the various sort of trade-offs in the individualized circumstances where oral versus injectable may make a difference. For me, I think this question hinges on that idea of this question asking about whether the oral formulation offers a substantial opportunity. So it's not necessarily asking us to sort of net out which one might be better in population or let alone the health benefits, but if there is, as it sounds like there may be for some subset of the population advantages here, I see that as a substantial opportunity, even if for others some of the other factors we've talked about may trump those. So for me, that's where I come down on agreeing with this question, somewhere between agreeing and strongly agreeing.
So let's say hypothetically 20% pursue injectable, 20% want oral, and the rest are fine with either. The proper vote would still be agree, because there's some people for which the oral version is preferred.
That's how I view
Yeah,
it.
no, I think and that makes sense to me. Does anyone else want to say anything or have questions or comments, or just wants to say how they want to vote in an attempt to influence others in this public deliberation? Let's go ahead to vote in that case. $12 votes, 2 more. 14 votes. Okay, 10 agree, with 1 strongly agree, and then 1 disagree, and 2 neutral. Does anyone want to say anything else about this? I won't put anyone on the spot, but if you want to say something about how you voted and why you voted, feel free to do so. Okay, hearing none, we will move on. Now we are on the long-term value for money votes. Next slide, please. Given the available evidence on comparative clinical effectiveness, as well as incremental cost effectiveness, and considering benefits beyond health and special ethical priorities. So just to be explicit about this, the comparative clinical evidence, is this better? Is that better? Cost effectiveness is the incremental cost effectiveness ratios, and then integration of the benefits beyond health and special ethical priorities. None of these mean to ask the total affordability for the country. It's just the cost effectiveness for specific populations. So I think it is an important distinction to make on this review in particular. Let's go on to the next slide. What is the long-term value for money into integrating those three things, but not integrating the net budget impact of injectable semaglutide added on to lifestyle modification compared to lifestyle modification alone at current pricing? Maybe we should hear a bit from the modeling team at ICER.
Yes, I can talk about cost effectiveness results. You can find the results in Table 13A and Table 14A in the evidence summary based on the current pricing. So all these three interventions increase the drug acquisition cost, but there is a cost offset effect. And so the total cost is higher compared to lifestyle modification by about $80,000 on one's lifetime horizon. And then there is incremental QALYs and EVLY gains of about 1 to 1.5, depending on the interventions. And so we have incremental cost effects ratio of about $60,000 to $70,000 for all of these three interventions, with tirzepatide had the lowest cost per QALY or EVLY gained.
So at the risk of wandering into controversial topics in health technology assessment and cost effectiveness research, how should we think about what that number means? What is a reasonable value in terms of numbers? And I recognize this is a slightly controversial question that I'm asking.
So let me jump in on that, Jason. I think that, obviously there are disagreements about where we should consider things cost effective. ICER has typically felt that 100 to 150,000 is a reasonable range. You sometimes, if you look at some of the literature on this for the United States, you see numbers ranging from the mid 80s to about 105,000. So there are health economists who would go lower than ICER would go, but these numbers are all kind of lower than that. So I don't know if any of the health economists on here want to disagree and say, gee, this still doesn't look cost effective to them. But I think these numbers are in a range that most, if you buy the numbers, which again, the health economists on here don't have to agree with these numbers, but I think most of them would say that the threshold is higher than where most of these cost effectiveness numbers are falling.
So $60,000 per quality adjusted life year, pretty good value, sounds like. Unless, as
I'm looking around to see if any of the health economists on here want to say, no way.
He's acknowledging there may be heterogeneity of opinion. Does anyone want to disagree with that? This is a highly controversial topic that I don't think is ever going to get settled. Does anyone have anything to, oh, Steve, go ahead.
Yeah, just to add again that reiterate my comment from before that I think the model is a little bit bullish.
Thank you. So optimistic model. Jim, I'll let you, if you, quick question, but we are behind and I don't want to eat too much.
No, it's not a question, it's a comment. I just want to underscore, I think David's right, Dr. Rinda's right. These are very impressive cost effectiveness numbers. And I don't see, in my read, I don't see this as sort of being overly bullish. This is a pretty remarkable innovation from a cost effectiveness perspective.
Thank you for sharing that. Let's go ahead to vote. Four votes in. 6, 8, 9, 13 votes. One more. 14 votes. Let's see the results. Okay, 12 high long-term value for money at current pricing, and 2 felt like it was intermediate, with none saying that it was low value for money at current pricing. Thank you. Next slide, please. And I think we have 2 more. We want to make sure to have at least some of the break left. What is the long-term value for money of oral semaglutide, not IV semaglutide, this is oral, added on to lifestyle modification compared to lifestyle modification alone at assumed pricing? Dr. Lee Woo-Jung, do you want to give us your sense?
Yeah, for oral semaglutide, the cost effects results are pretty much the same. It's slightly, regarding cost per quality or ABLY gained, it's slightly higher than injectable semaglutide or tirzepatide, but it's still $75,000 based on our analysis with the current net price. With the assumed price, the price was assumed to be equal to injectable semaglutide.
Because it's not in FDA, it's not post FDA approval.
Exactly.
Yeah. Okay, we don't have a price, so they made an assumption. Anyone want to say anything? It sounds like it's similar to the last one. Let's go ahead to vote. "13 votes, 14 votes. Let's see the results. Same as it's a similar ICER, so a similar incremental cost effectiveness ratio, 12 high long-term value for money and 2 intermediate long-term value for money. Next slide, please. I believe this is the last question before our break. What is the long-term value of tirzepatide added on to lifestyle modification compared to lifestyle modification alone at current pricing? Dr. Lee, do you want to tell us what you think?
Yes, again, the results are similar. It has the highest incremental cost, but also comes with highest incremental qualities or EBLYs. And so we see cost per quality gained around $56,000, which is slightly lower than injectable semaglutide.
So maybe a little more money, but a little better health status, and comes out like a little better actually than the last 2 votes. Does anyone have any statements, questions, comments? We welcome anything. I don't see any. Let's go to vote then. "14 votes. Let's see the results. 13-1. So a slight change in someone got persuaded by that slight change in incremental cost effectiveness ratio. I believe that is the end of the voting, if I'm correct. And thank you for your partnership in getting through this. This is a longer session. We want to give you a bit of a break before we delve into what I am absolutely certain is going to be a vigorous and very important policy roundtables. And then I'm really just reiterate my gratitude to have a policy roundtable with the manufacturers there, with payer community, clinical experts, and patients. It's everyone we want to see at the table, and I'm just really looking forward to it. We will see you back at, let me just get the right time here, at 2:15. I guess maybe you want to just say do 2:20 to make sure everyone has 10 minutes.